Thanks for the introduction, Daniel. Dear colleagues, I will stay with delayed drug hypersensitivity before the break, and I would like to introduce you into multiple drug hypersensitivity. As you know, drug allergy is rare, and even rarer is multiple drug hypersensitivity. And I would like to show you when do you have to think on multiple drug hypersensitivity and how it behaves. So, there are a lot of names in the literature about multiple, like multiple intolerance syndrome, multiple chemical sensitivity, and so on. And it's really important that you do not confuse it with multiple drug hypersensitivity. So as you see here the definition, multiple drug hypersensitivity, it is about real proven allergy to two unrelated drugs that are not associated by cross-reactivity, by pharmacologic effect, and so on. We in Switzerland mostly focus on positive skin tests and in vitro tests. Some centers do also include patients with positive drug provocation tests. But as you can see, when you include patients with positive drug provocation tests, you have a mixture of patients with real drug allergy and patients with, for example, intolerance to antirheumatic drugs. Now I show you a case, a typical case of multiple drug hypersensitivity. You see it's a long career of this patient. He has regular visits in our department, and it started all with one event with address to phenytoin. He had a meningioma, he had epileptic reactions, and he was treated with phenytoin, and he had a dress. And from this point on, he developed one drug hypersensitivity reactions after the other. Over a very long time, you see he had MPE to cefuroxime, then radiocontrast media, multiple reactions, then interestingly, AGEP to clindamycin. And at the end, he did not tolerate any radiocontrast media, so he was sensitized. Over the year, he was sensitized to all these drugs. Now you can see there are, in multiple drug hypersensitivity, you have different behavior. Basically, you have three forms. You have a simultaneous form. This is when someone is treated at the same instant with multiple drugs. He makes one drug hypersensitivity reaction, and then he is sensitized to two or more drugs. Then you have a sequential form. This is really often. You have a severe drug hypersensitivity to one drug at the beginning, and then in hospitals, doctors always change the drugs. There are new drugs, others are stopped. Then new antibiotics are introduced, and then the patient makes flare-up reactions and develops a sensitization, also to multiple drugs. And then the third one, that's the patient I showed you before, is a distant form. So you have one drug hypersensitivity reaction in the beginning, 2 years later you have a second one, 4 years later you have a third one. Now these three forms are not limited, so they can be mixed. You can have a person that has a simultaneous form, and then later on he develops a distant form. So they can all be mixed up. It's quite interesting to see when do you have to expect multiple drug hypersensitivity. It's mainly in delayed type hypersensitivity, and one reaction is most often associated, and that's stress. So in stress patients, you have a high probability that these patients will develop other drug allergies in their future. There are also other drug hypersensitivity reactions, MPE, Stevens-Johnson 10, AGEP, and also in some cases with strife, we also saw such a behavior. Now, why is MPE so often? There is a certain similarity between these two drug hypersensitivity reactions. You have some MPE, severe MPE, that have some overlap to stress, and in some MPE you do not know if it's a mild stress, if it's a precursor of stress, and so you will find, especially in severe MPE, you will have a higher probability that these patients will react to multiple drugs, as I showed you this morning. Now I show you the cytokine profile of 2 patients with MDH. We talked this morning already that we can see, based on this cytokine profile, or that we can see which reaction these patients have made. On the left side, you see the cytokine profile of the case I showed you before. On the left is the phenytoin. You see it's an IL-5 predominance, but all cytokines are elevated. The second one is cefuroxime. Here this patient made MPE. Also here you have an IL-5 predominance, but the stimulation index is lower, and the other cytokines are on a very low level. On the right side, the LTT profile looks different. Here again, address patient to meropenem with a sequential form to piperacillin tazobactam. So he had meropenem, 2 weeks later piperacillin tazobactam, he made a DRESS flare. And also here you can see, in this case, all cytokines are elevated, so here it would fit to DRESS. Now the question is, DRESS and what follows? It's not, the behavior of MDH is not that when you have one reaction that you will have the same later. So it changes. At the beginning, patients often have DRESS. The second reaction is mostly different. You can have DRESS again, but very often it's MPE or one of the other. We looked at the role of the drug dose. You mainly see, especially in DRESS and also MDH, that the drug dose is very important to develop drug hypersensitivity reaction. And when we looked at the first reaction of MDH patients, there were a lot of drugs that are in a high dose level, like 1 gram, 2 gram, up to 12 gram per day. And we thought that high dose drugs are associated with the development of DRESS and also with the development of MDH. Interestingly, when you look at the second reactions in these patients, the threshold to develop a drug hypersensitivity reaction is lower. So here also low dose drugs or lower dose drugs had the possibility to react. A short excursus to latency period. They are typically DRESS latency periods, 10 days to 2 months. And in second reactions, it was much shorter. It's similar to flare-up reactions. So new drugs were introduced, and after 1, 2, 3, 5 days, the patient reacted. And you see here the difficulty. How can I see if someone makes only a relapse or if he makes a persistent sensitization? Which drugs are involved in MDH? Typically DRESS triggers like antiepileptic drugs, vancomycin, sulfonamides, and there is one peak, and it's interesting in Switzerland. In Switzerland, penicillins and in general beta-lactam antibiotics are the drugs that are most often involved in DRESS and in multiple drug hypersensitivity reactions. For subsequent reactions, you have a certain shift to other drugs like radiocontrast media, clindamycin, proton pump inhibitors, and so on. But you have also the typical like anti-epileptic drugs and beta-lactams. Now, in a study we looked how often DRESS patients do develop relapses or flare-up reactions in their disease course. And what you can see here, that over half of these patients will have a relapse. And when you look at all relapses, that approximately 2/3 of the relapses are associated with drugs. So you see the difficulty because these relapses can be precursors of a persistent sensitization, and you have to look very, very good if a relapse will go down or if the disease course goes up for a few days. Now an outlook, we are doing a study together with ADR-AC. The question we have is, why do some patients develop MDH and why others do not? Even in DRESS, you have DRESS patients that are only sensitized to one drug, and other DRESS patients develop a sensitization to multiple drugs. So we made a study with 4 arms. We included DRESS without MDH, who were sensitized to one drug, DRESS with MDH, then MPE without MDH and healthy controls. And we looked at the clinical presentation, cyto-LTT, and T-cell phenotype. Now I show you the very preliminary data. It's practically raw data we have at the moment. In general, we hope to find a difference between DRESS patients with MDH and DRESS patients without, and we did not find any difference. What we found is when you compare DRESS patients to healthy control, that certain markers, in part activation markers like CD38 or CD69, then also exhaustion factors like PD-1 are different in these 2 groups. We did not look at the acute stage. We did look at the resting stage when the disease, when the DRESS or any drug hypersensitivity reaction is gone. And what we think is that DRESS is practically a chronic disease. Even when DRESS is resolved, you have it remains there is a remaining T-cell dysregulation that persists, and that these patients have a higher probability in the future to react to other drugs. So I think in DRESS it's only a matter of time, and it's a matter of treatment to develop an MDH. The only difference we found is in LTT. We showed you already this morning that in LTT you have an IL-5 predominance, and when you look at our data, patients with DRESS without MDH and those with MDH, the patients with MDH have a much higher stimulation index compared to the other. We do not know the significance of these data, but it could be a risk factor or a risk marker in the future that you could tell that patients with a high stimulation index in LTT are prone to further reactions, and that these patients should avoid all unnecessary drugs. So in summary, MDH is rare, but when you have DRESS patients or patients with severe MP, you have to think about it, you have to look for it. Then MDH does not present with the same drug hypersensitivity reaction. There are multiple different drug hypersensitivity reactions in the course. Most often involved are antibiotics and high-dose drugs. Then flare-up reactions, be aware that they can develop persistent sensitization, and our study suggests that DRESS and MDH are practically the same or a similar disease, and that DRESS is a chronic disease that even persists in the resting state. I would like to thank my team at the Inselspital for conducting the study, and also the team of ADR-AC, especially Daniel Jährli and Lester Su for the data preparation and conducting all the laboratory stuff. Thanks you.
Thank you, Lukas, for this talk about this interesting topic. Sometimes we don't know why people are actually developing hypersensitivity to one drug, but to several drugs it becomes even more complicated. Any question from the audience before the coffee break? Yes?
Thank you for the talk. I would have one question. So often with stress, we see a upregulation of the soluble CD25. Have you checked in this patient with MDH whether you have a long-term also activation or indirect sign for lymphocyte activations in the blood, and see whether it could predict, if that kind of marker could predict the risk of the developing MDH?
So the data are very preliminary. So we have I think we do not have enough patients to tell generally that this is a risk factor. So we would have to include much more patients. But it's something that it's the only difference we could find. So at the moment, it's not.
We look at the phenotype after resolution. So it was months after the resolution of the acute phase. And even here we see some basic activation that is higher than the healthy controls. So apparently there is some dysregulation. If it's exhaustion or upregulation, it's still difficult to say.
And included patients are even such that were 1, 2, 3 years later we did all the testing.
Yes, Oli?
To your question, we have done an earlier study on this and saw that the reactive T cells are the CD4 positive CD25 dim compartment. So there is a pre-activated compartment. There is no problem of T regulatory cells. We first thought of, okay, this is a deregulated problem because there is no Treg help anymore. But actually we saw, this is a study by Barbara Daubner, that all the reactive, in the multiple drug hypersensitivity, all the drug reactive T cells rest within the CD4, CD25 dim compartment.
Final conclusion is you should be aware the rest is a severe disease. And what kind of severe disease is it? It's an acute graft versus host disease. An acute graft versus host disease. So you have the same pattern like in graft versus host disease, artificially induced by your drug. And now, when you have a chronic graft versus host disease, you find the same parameters in these patients. The PD-1 upregulation, CD38 upregulation. Actually, stress is a severe disease which lasts for many, many years. And has a remnant of a graft versus host disease. And that is quite problematic. And I mean, if you have a child who has already a stress, she will suffer all the life and has the threat of a graft versus host disease. That's we are not aware of that, but basically most of our drug hypersensitivity reactions are mild, transient, and they are clinically mild, but stress is indeed a severe disease, and it's very serious, and it's very serious for the patient. And actually, I would be very happy if the industry would recognize more. They are very much focused on Stevens-Johnson syndrome, and they are afraid of that. But basically, we have more deaths due to stress in Switzerland than to Stevens-Johnson syndrome. And we have now a very good specialist for that, Lukas.